Hi guys, it's Polly and Taylor here from Beaten Jeans.
And today we have the honor and the privilege of talking to Dr. Jeremy Davis, the Surgeon-in-Chief at the National Institute of Health.
He happens to be our doctor. We are not affiliated with the NIH in any way. And without further ado, we're going to invite him in.
Let's bring him on.
Hey! There we go. Technology sometimes, right?
Oh my goodness.
Hi, Dr. Davis.
Hey guys, how are you?
There you go.
Yay!
Oh, I got to get something to set it up on. So I can talk with my hands.
Well, we just want to say thank you so much for taking time out of your busy day to sit down and talk to us. We've had so many people write in questions that they want to ask you, so we just very much appreciate you being here for us today.
No problem. I wish I was more technologically, savvy.
We wish we were as well.
Okay, so we just kind of want to start out with the basics. So where are you from?
Where am I from? Yeah. Tampa, Florida.
Wow.
Tampa, Florida.
And are you married?
Yes.
And you have children?
Oh, 3 children. Is that your wife and 2 children?
We can't see very well. Oh, no, those are 3 babies.
Kids. Oh, my
God.
So cute.
Yeah, those are the kids.
Oh. And we are curious to know why you chose GI as your specialty.
Well, I think things just work out the way they work out. I kind of always liked, doing surgery in people's abdomens and their belly, and there's lots of different things in there that are kind of cool and problems that need fixing, and so it just, I don't know, it's just like one of those things that you're drawn to for no particular reason.
Right.
Right. Well, you had a calling, and Catherine, you are the man, the myth, the legend, the man with the magic hands.
Yeah.
We get that.
Yeah, I don't know about that.
Now, why specifically CDH1? How did this study begin?
Yeah. So, it's kind of weird or cool, I guess, but when I began thinking about what I wanted to do kind of for the rest of my life, I thought, well, stomach cancer is a bad cancer, and not a lot of people do research in stomach cancer, and I thought, well, geez, that sounds like a challenge, right? And when I came to the NIH, I realized that there had been some CDH1 patients here years ago, and I understood that if you wanted to treat people with advanced gastric cancer, sometimes you have to understand how that cancer begins. And so I thought, well, geez, in the United States, we don't really see a lot of early stage gastric cancer, right? A lot of times we see it, it's very advanced. But with CDH1 patients, you can see stomach cancer super, super early. And so the idea was, if we studied patients with CDH1 and we understood why they got stomach cancer, it would help us even to understand patients who develop advanced gastric cancer or metastatic stomach cancer and help us treat them better. So the reason I started studying CDH1 was because I think it will help us understand stomach cancer in general better. But once I got started down the path of CDH1, I was like, hey, there's a lot of work to be done here. We don't know a lot about CDH1, and why don't we? And so there you go.
Right. Now, okay, so the study. So are you just studying? Okay. So how many people are enrolled in the study currently?
Currently, we're probably somewhere between maybe 550 and 600 patients. So it's pretty big. We got a lot of patients in the study.
And are they all necessarily carriers of the CDH1 gene mutation?
No. So I would say the vast majority have a CDH1 mutation. Then there's a group of patients that kind of look like they would have CDH1, right? There's a family history of diffuse gastric cancer or lobular breast cancer. But when we do genetic testing, we don't see an obvious genetic cause, right? So they're kind of a little bit of a mystery. And then there's a group of people out there that have a hereditary stomach cancer of some other kind. And there are some other hereditary forms of stomach cancer. One of them is called GIST. And then there are also some other forms of gastric cancer that are related to gene mutations, things like that are called like Lynch syndrome and something called GAPPS, GAPPS.
I did not know that GIST was hereditary.
It can be. It can be.
Okay, so not in all cases.
No.
Okay.
No.
Okay.
Hopefully not in our case.
Yeah.
No, I don't think so.
Okay. Okay.
So the purpose of the study is to study all of these different cancers and potentially find a cure for them. Is that what it is?
Yeah, I'll tell you, I think the goal is kind of two things, right? The goal in one way is to provide, in some ways, just expertise for something that's super rare. And as you guys know, when you start talking about CDH1, there's not a ton of expertise out there because it's so rare. So I think at the most basic level, it's kind of like, well, let's be a source of good information for people out there. But on kind of a basic level in the research side of things, I think things have evolved in kind of two areas. Number one is certainly we want to find better treatments, more effective treatments for gastric cancer. And in this case, when I say gastric cancer, I'm talking about gastric adenocarcinoma, which is the most common form of gastric cancer that arises from the inner lining of the stomach. But I really think the other part of it is it related to CDH1 is really understanding why people with CDH1 are at higher risk of stomach cancer and, oh, by the way, lobular breast cancer. And really, more recently, why is it that some people with CDH1 will never develop stomach cancer? Because I think if we can understand that might provide us some insight into how we might prevent it, aside from taking out people's stomachs, which I think is kind of crazy.
Now, how close are you getting to answering those questions?
I think every day, every week, every month, we're a little closer. But, realistically, what does that mean in terms of months or years or whatever? I think we might be 5 to 10 years away from running, let's say, a clinical trial where, maybe 5 years away from running a clinical trial, let's say, where we give people a medication or a drug that we know targets those little early cancer cells that develop in people with CDH1 and might prevent those cells from ever kind of growing or progressing and causing cancer. And that would be a great way to get away from taking out their stomach. So how close are we? I think based on some of our research and some of the research that's being done elsewhere, I think we might be about 5 years away from running the trial. Now, you run the trial, you have to analyze the data, then it could be, years after that. But I think if there are kids out there with CDH1, and they probably don't know it, that are, 5, 6, 7 years old, my hope would be by the time they're adults, we're in a much better place.
Is this the medicine that Perry Guilford's working on?
So Perry's working on multiple things, but yeah, what he and I and other people talk about is exactly that. Can we find a drug that already exists out there to do what we want it to do? It's a lot harder to develop a drug to do what you want it to do. So he's found some drugs that he thinks might work, and he's in the process of testing those. Usually you test them like in mice first and stuff like that. But yeah, that I think most people that are working on CDH1 research, that's where many of us are focused.
Wonderful. It's so exciting. It gives us so much hope.
I know it does. Okay, so you say that most people with CDH1 do carry these cancer cells, which we refer to as Signet cells. Is that correct? Okay.
Yeah. Signet ring cells, because they look so in the movies, I don't know anybody that wears one. The guys that wear, like the Italian guys or the British guys, they wear the signet ring with the coat of arms. If you look at that on the side, what you see is a round circle with a little kind of, thicker part on one side. And so 100 years ago, some pathologist was looking at these cells under a microscope and trying to describe them, and they said, oh, well, it kind of looks like a signet ring.
Oh.
And so the name has stuck.
Oh.
And so when we say a signet ring cell, it's just a type of cancer cell, and it's a cancer cell that we see the most frequently in this type of diffuse type gastric cancer that people with CDH1 are prone to get.
And you explained to us before that you believe the majority of the people that have this mutation are sitting with stage 1A in their stomachs.
Yeah, and I don't know if I would have known that 5, 6, 7 years ago, but if we just look at the last 100 people that we've done a prophylactic total gastrectomy on, 95% of the time our pathologists can find those little early cancer cells already in the stomach, and they're there in these little tiny areas. I mean, when I say tiny, I'm talking so tiny, even under a microscope, you have to magnify it quite a bit to see, but they're there. And the conundrum is that we see them in people with CDH1 as young as 20 years old, and people with CDH1 in their 80s. And the question is whether or not they're ever going to decide to kind of wake up and, start doing something bad.
Right, that's the magic
Therein
question.
lies the mystery.
Right.
Yeah.
Yeah, that's the $1 million question.
Yeah, why does it turn on in some people and some people it does not? Right.
Yeah.
So, okay, so you're saying about like 5% of people or stomachs that you remove, they don't show any signs of Signet cells, about that number?
We can't find them. So what I believe is we can't find them because you know what? It's just hard. It's hard. If it may be hard to imagine, but when you take out somebody's stomach, and you do it all the time, you take out the stomach and you look at the inside of the stomach, it's a large surface area, and it is really, I would say, almost nearly impossible for the pathologist to look at every square millimeter or whatever surface area of that stomach under the microscope. So my belief is in those 5% of cases where the pathology report comes back and they go, well, we didn't see any signet ring cells, it's because we didn't look hard enough or we just missed them. And so my belief is they're pretty much there. That 5% is just our miss rate. That
makes sense.
So could you theoretically then miss seeing a stage 1B or a 2A, or is that different entirely?
So the reason why these little early stage cancers, these so-called T1A cancers, are so hard to find is because you can't see them. They live under the surface of the stomach, and we only find them either if we take enough random biopsies during an endoscopy or after gastrectomy, right? At least in our experience, what we found is that if somebody develops growth in those cells, meaning they've grown now to a higher stage, a T1B or T2, more than likely, we're going to be able to then see that with our naked eye on endoscopy. Mm-hmm. And I've only seen that in 3 cases in our cohort of patients here at NIH. But it is, I think, the thing that worries people, right, is that, these things are sneaky. And yeah, I know. I mean, that's the part that we just, we don't know.
Right.
That's the scary part.
Well, and one of my concerns is every time we go in and do those endoscopies, we're leaving little white scars behind. And I think that you guys kind of can see when it's more advanced, a white patch. Am I correct?
Versus a scar from
can you differentiate those markings?
Yeah, so this is a great point that you're bringing up, because I think it's now, and in my mind, it's going to become a little bit of something that we need to dispense with going forward. So there is a group, and they've published on this, that, we think we would see on endoscopy these little pale areas in the stomach that might be suggestive of where those little signet ring cells are. The truth is, when you read the research paper that these folks wrote, those white little pale areas were not very specific for signet ring cells, meaning if you saw a little white pale area, only 7% of the time would you find signet ring cells there. Well, that's pretty, bad odds, right? The scars that may be left behind after biopsies, number one, look different.
Okay.
Okay, so they don't look the same as those pale areas. And I think what we're learning is that it's very rare for us to see something that then is associated with those, at least those little microscopic cancer cells. If we see anything abnormal, it's likely going to be something more advanced, like a T1B or T2, you know.
Okay, well that clarifies that.
And
So
that's easier to see on the scope. So that's not necessarily seen after gastrectomy or scope. Okay.
And I want you to think about that like, you know, people that undergo colonoscopy, right, for colon cancer screening. You get a colonoscopy, what's the GI doctor looking for? Well, they're looking for anything abnormal, and they're looking for polyps. The polyps are kind of those things that could potentially lead to cancer, so they want to see those, and then they're looking for anything obvious. Now, is it possible that when they scope people, there's something at the very, very earliest stages that, you know, they wouldn't even be able to see unless they took out the entire colon and examined it under a microscope? I guess it's possible. But what you're really looking for is the obvious stuff. And I think when it comes to CDH1 and surveillance, that's probably going to end up being the greatest value right now of the endoscopy, is at least making sure we don't see anything that's, you know, really abnormal, like, hey, that's not supposed to be there. Because if we don't see anything like that, then at least we can say is that more than likely what you probably have are these little T1A cancers in your stomach. And, you know, as long as they're not doing anything, maybe, just maybe, you can continue under surveillance. And remember, we haven't talked yet about whether or not gastrectomy should be done more than surveillance, but that's kind of how I would look at it.
Well, is that more of like a personal decision though? I mean, like if someone just can't live with the worry and...
Yeah, I think, listen, you know, I don't have the exact numbers, but if you look at all the people in our study, I would say, you know, around 140 or so people have chosen to have a gastrectomy, and probably around 200 people or so have elected for surveillance. And I think those decisions on each, you know, to each person are totally unique, right? Maybe based on a family member that, you know, died of stomach cancer, maybe based on the fact that they don't see much stomach cancer in their family. So,
yeah,
you know, I think it's definitely a personal decision, at least when it's not obvious what we should do. I should tell you that in some cases I've told people, hey, you know what, no surveillance. I think you need to have your stomach out.
Okay.
So
and that's usually when people have like a large family history of the gastric cancer.
yeah, either large family history. Sometimes the biopsies under the microscope, you know, to me have, you know, begun to look a little bit different or more concerning. There are some things that we're learning about, you know, maybe the size of these clusters of cells and how many biopsies are positive, and some subtle things that we're learning. But yeah, there are times where I tell people, you know what, that surveillance may not be for you.
Okay. That's
you know?
good. I think people want to hear that. They want to hear that. They want to be reassured in their decision making. Now, so now that there's so much testing going on, genetic testing, do you feel like the rates or the percentage of people developing this cancer that test positive for CDH1 have gotten smaller?
like when we first found out, it was like an 87% chance of developing.
Do you not have those percentages?
Yeah, so this is a great question. So, you know, in a couple weeks, we're going to have this symposium here at NIH. It's virtual, but it's hosted by us. And one of the things that we're going to talk about there are some recent data that we've put together with some of our colleagues around the country to look exactly at that. So you're right. Many years ago, and even now, there are some genetic testing reports that'll say, you know, your lifetime risk of stomach cancer is, you know, 70%. The problem is those numbers are overall probably way too high. Yes, is it true that maybe some families, gastric cancer maybe seems to be kind of rampant in that family with CDH1? But if you just look at people overall, the numbers that we're starting to see are a lot lower, and the numbers that we're going to present at this symposium and then publish are probably in the 25 to 40% range.
Okay.
Which is still high,
right?
You know, but it's certainly not 80%.
Right.
Right.
Do you find it more in men than in women?
So it's so funny. In a lot of these studies, the risk in women seems to be slightly higher.
Okay.
But remember, these estimates, our calculations based on families, let's say, and people like you that are in our study. And you might imagine that if we had thousands of patients and thousands of families and we had equal numbers of men and women, maybe those numbers would kind of shake out and be more equivalent. So those numbers could be skewed a little bit just by the nature of the people that are being used to make the calculations. Right, but it's curious that it's a slightly higher in women for some reason.
Yeah. Okay, so I want to get into the surgery.
Yeah, well, Catherine.
Okay.
Catherine wants to know. Catherine from Texas.
She wants you to describe the surgery, the processes of, like, talk us through it. Can you do that?
Like, how do you remove somebody's stomach? You've removed 140. Is that what you just said at the NIH?
For CDH1, yeah. And so I guess I would describe it like this. So we start out in the operating room by having to identify the blood supply to the stomach, right? Because in order to take the stomach out, you have to cut off its blood supply too. So we start off by disconnecting some of the blood vessels that are on the lower part of the stomach, called the pylorus. And we have to divide that lower part of the stomach, and we do that actually with a stapler. It's not like, this stapler. It's a surgical stapler, and it basically lays down staples and cuts in between so we can divide things without opening it up, right? Because on the inside of the intestines and everything are bacteria and things like that. You don't want to let those out. So we have to disconnect the lower part of the stomach. So we disconnect right at the connection of the stomach to the first part of the intestine called the duodenum. Once we disconnect that, we've disconnected that blood supply down there, then we basically take the rest of the stomach and disconnect it from where it's attached. It's attached a little bit to the large intestine or the colon. Mm-hmm. It's attached a little bit to the spleen, which is kind of like, you can imagine, a filter for your blood. Okay. And then there's another major blood vessel that comes up to the upper part of the stomach. We have to divide that. And then the last part, at least for me, that I divide is where the esophagus connects into the stomach. Okay. Same thing, we cut that with a stapler. When we're done with that, by the way, for CDH1, we want to make sure that we've gotten everything out, meaning all stomach cells that are lining the inner part of the stomach. Because if we leave any of those behind, in theory, you could still develop stomach cancer. So in the operating room, what I usually do is I open the stomach, and I check the margin at the esophagus, and I check the margin at the duodenum down low, and I send those to the pathologist so that they give me an answer in about 20 minutes to say, hey, you got out all of the lining. You don't have to worry about anything.
Okay, to see where the stomach begins and where the stomach ends.
So basically, you know before you close your patient up that you've gotten everything.
That's
because we don't want to leave. And the reason why that is, by the way, is that I've seen this in a few patients where you can find those little signet ring cancer cells within a millimeter or two of the transition from esophagus to stomach.
Wow.
So if you're not careful, you can leave some of that stomach lining behind and you don't realize it, because it's not as obvious when you're in the operating room, like, hey, there's not like a dotted line that says cut here. So you gotta, gotta be careful
about that.
So then you're taking the lower intestines and attaching it to the esophagus, but you also have to address the gallbladder junction, right? At that time?
Yeah, so what happens is, your liver makes bile, your pancreas makes pancreas juice, and all that stuff is important for you to digest food. So that stuff has to make its way down through part of the intestine, and we still have to make sure that it can kind of connect and mix with the food. So we end up making two connections. One, when we pull up the intestine to the esophagus and sew that there, and then down lower we make one more connection so we can get that bile and everything that's coming from another direction to mix with the food. And so it's funny you ask this. We have a video that we made in the operating room that we'll probably post at some point, but it for people that aren't squeamish, it shows you the operation, and it shows you step by step, and it's sped up, so that you're not sitting there for 2 hours, watching kind of boring stuff, but Yeah, I think, it's hard to kind of sometimes wrap your head around it. So I tend to draw pictures sometimes for people. So, yeah.
That's interesting. And that's public for us to watch?
Well, he hasn't posted it yet.
Okay.
I haven't posted it yet, but we made it because, people are curious, other doctors are curious, people, nurses, I think it's important to see it because it's hard to just kind of imagine it in your head or even in a book. It doesn't always make sense.
Mm-hmm.
So.
And this surgery takes you how long?
About 2 to 2.5 hours.
Okay.
So quick.
That's really quick. And then you do open surgery versus laparoscopic, correct?
I do open surgery now, and I wonder, if I should be doing, it laparoscopic or robotic. But I'll tell you that I spend a lot of time talking to people that do it laparoscopically or robotically, and I've looked at a lot of the data that's published on laparoscopic and robotic surgery. And so I'll tell you this, laparoscopic and robotic surgery is not better just because it's new technology, okay? Laparoscopic and robotic surgery is just a tool, and we have to decide when best to use that tool. So I'll give you an example. If you were going to get your appendix out or your gallbladder out, you'd want it done laparoscopically because you can get out of the hospital the same day, If you were a woman and you're going to have a hysterectomy, nowadays they're doing them robotically or laparoscopically. You can go home either the same day or the next day. Same thing for prostatectomy for men.
Okay.
But for stomach surgery, it's not that simple. Nobody's going home in 2 days, 3 days, 4 days after gastrectomy. And the advantages of the robot in general are smaller incisions, less pain, quicker return to work. But as you've probably learned from people, is that when you've had a gastrectomy, the issues are less about, recovering from the actual surgery, and they're more about living life without a stomach. And so if you look at all the studies that have looked at laparoscopic or robotic versus open total gastrectomy, you look at people about a month later and definitely look at people more than a month later, you really can't tell any difference.
Right.
And so my take on it is that you get one good shot at an operation that's supposed to last you the rest of your life. And one of the things that I don't like right now about laparoscopic and robotic total gastrectomy is most surgeons use what's called a circular stapler. And that makes the connection between the esophagus and the stomach. And it's notorious for narrowing down and causing what's called a stricture that then requires somebody to go in with an endoscopy and dilate it.
Right.
And if you look, there's a big institution that does a lot of these, and their rate of stricture was something like 15 to 17%. I think that's too high. Knock on wood, I've had one stricture out of like 130 or 140 patients. So I think, I just want to give people the best operation. If robotics was best, hands down, I would do it. But it doesn't have a clear advantage, and that's kind of the long
I like
version
the
of my
idea of you opening me up and getting a really good look in there.
And listen, it's not a huge incision. I mean, it's really not. I mean, it's enough probably for me to get my hand through. So if you measured that, it's maybe about 8 centimeters or 10 centimeters. You can do the math on how many inches that is, but it doesn't need to be a huge incision. And it's people are still up walking the halls the day after surgery, and people are still able to go home 5, 6, 7 days after surgery. So it's not like it's, somehow barbaric compared to laparoscopic or robotic surgery.
Scar left.
Right.
Yeah.
And like Catherine's, it makes her look like she's got a 6-pack.
I was thinking I should have you tattoo your signature next to the scar.
I could think of some better tattoos.
Okay, so I want to go.
We do need to touch on this subject because I think we've had 6 people ask it while you've been speaking, and we've asked you this question before. We know the answer is it's impossible, but they are saying they want to know about the vagus nerve.
Yeah, and its relation to feeling hungry.
Yeah.
Well, hungry?
Well, so there's a couple things. The vagus nerve has a lot of different functions, but hunger isn't necessarily the main function of the vagus nerve. What I'll tell you is it's likely not possible to really preserve the vagus nerve, at least the anterior. There's two vagus nerves, left and right, and as you come down into the stomach, they kind of turn a little bit, and we call them anterior and posterior. But the point is that you might be able to preserve some branches of the posterior vagus nerve, but for the most part, you're not. I think hunger in general is more complex than that. There are a lot of hormones that are produced by the stomach that we've learned a lot about in the last 10 to 20 years that are important in hunger and satiety and all those kinds of feelings that you get when you have a stomach. So we're only just learning about some of those hormones. So again, those hormones are going to be gone if they're produced by the stomach, regardless of whether or not we save the vagus or not. People's hunger cues just become different after gastrectomy. And our dietitian, Rachel, is excellent when it comes to talking about this, but you basically learn to kind of key in on those things because you're right. Some people will say, I just don't have the same feelings, to eat that I used to.
Right. And I don't think I'd want to feel hunger
If you
I
can't
couldn't eat.
yeah, why would you want to be hungry?
No.
I don't know. It's interesting.
It is very
So
interesting.
the other thing I want to ask you is a lot of people experience bile reflux. And does that have anything to do with the roux junction or the gallbladder junction placement?
So,
Like how high
yeah,
and how
so
low?
it has something to do with the length of that roux limb. And I was looking to see if I had something to show. But basically, the longer that roux limb is, the harder it is for bile to get back up into your esophagus. Now, the trade-off is the longer that roux limb is, the more weight you're going to lose. Okay, so if you were undergoing bariatric surgery for weight loss, right, if you were obese, you would want that roux limb to be long because the longer it is, the more weight you're going to lose. Okay, and you're not going to have much of any of bile reflux. But for you guys, or for people with CDH1, that want to have their stomachs out, it's a balance between wanting to prevent bile reflux, but also not wanting to cause excessive weight loss.
Okay.
And so I think what we've learned is that for most people, a roux limb of about 50 centimeters is good. I think what I've learned is that some people don't tolerate that very well, and they need one that's slightly longer. And it's hard to predict that ahead of time. I think we're trying to, begin to look at some of those things. But I think these are the things you learn after surgery, that people's bodies are different. And so one of those things are how well your intestines move, or so-called motility. If you have really good active intestines, then maybe you won't have much bile reflux. If yours are a little sluggish or slower, maybe you'll have more. Those are the kinds of things that if we could figure out before surgery, then we might say, okay, this is a person we need to maybe make that roux limb a little bit longer and accept the fact that they might lose a little bit more weight.
And could it relate to someone who's already having issues with acid reflux, like me? Like I have terrible acid reflux. Would I be someone who might have more issues with that?
So I haven't, or we haven't seen that yet, and I think part of that's because the mechanism's a little bit different.
Okay.
The cause of bile reflux is going to, after gastrectomy, is different than the mechanism for acid reflux, if you're walking around with a stomach. But it's a good question, because people say, well, if I already have stomach issues, am I going to have issues afterwards? And it's not clear that you will.
Now, if someone does have that bile reflux, can you go back in and change that roux to make it longer?
You can. And I've only done it a handful of times, so it's not something that I necessarily want to do, but I've done it in a few people because they really, really needed it. So again, I'd rather get it right the first time.
Absolutely. No more just one surgery is good.
Yeah.
Now, what is that person's life expectancy after total gastrectomy? Does that affect it in any way?
So it's a great question. I think there's no reason for us to believe that your life expectancy would be shorter, but it's true that after gastrectomy, you've got to worry about things like, micronutrients and, certain vitamins and minerals that your body needs to survive. So in theory, if you had a gastrectomy and you didn't get those vitamins that you needed as supplements or those minerals, is it possible you develop problems that then would, lead to a shorter lifespan? I think it's possible. But I also think this day and age, with the ability to check blood levels for those micronutrients, being, knowing that you can get those essential vitamins and minerals through a basic, daily, bariatric multivitamin, makes me believe that you could still live a long, normal, happy life. But listen, has anybody ever taken somebody's stomach out at the age of 30 and then followed them for the next 50, 60 years to see how they did? Not really. So, I don't think anybody can be definitive, but I don't see any obvious reason why you shouldn't.
Okay. Now, what is it that you're doing with the stomachs once you remove them? Are you studying them additionally? I know Perry Guilford was saying that you were keeping a couple of the stomachs alive and studying them, or something along those lines.
Yeah, that sounds kind of creepy.
Yeah.
So the main thing that we do, right, when the stomach comes out in the operating room, that my team comes in and we take a bunch of samples immediately because we need some of that tissue when it's nice and fresh, and the proteins and RNA and DNA are still good. Then that stomach goes to the pathologist, right, because it's important for them to look at that stomach and give you a good, diagnosis. But once they're done with that stomach, the rest of that stomach gets saved in basically little wax blocks called paraffin blocks. And then we keep those blocks because we can go back to those for subsequent experiments, in addition to any of the stuff that we took in the operating room, which typically gets stored in like a liquid nitrogen type freezer. So one of the things that we use that tissue for are to understand the origins of those little signet ring cells, and then why and how those signet ring cells progress. So we actually have some, hopefully some stuff that's going to be coming out or get published later this year, where we used dozens and dozens of patients, samples or stomachs to do that very research, and we wouldn't have been able to do it if we didn't have that.
Wow. That's so cool.
It's incredible.
It is incredible. Okay, so we know you're a very busy man and you have a lot to do today, but I just want to know, we have this question from Becca from Oregon. What has surprised you the most regarding CDH1 through your research?
I think a couple things. Number one is, had you asked me about 7 years ago if I thought that most people with CDH1 should get their stomachs out, I would have said, yeah. Mm-hmm. But I think now I'm kind of saying, geez, I'm taking out a lot of stomachs, and do I really need to take out all these people's stomachs? Are there some people that could keep their stomach? Because, what I do see on the back end is, how it changes people's lives dramatically. Mm-hmm. And not always for the better. It's a struggle, or can be a struggle. And it's not a struggle for everybody. And I don't want to make it sound like it's misery. But it's a different set of challenges. I think it's mentally probably harder than it is physically. But I think what I've also learned is that people with CDH1 or families where the CDH1 mutation is present are a super motivated group of people, to want to not only obviously help themselves and help their families, but, maybe help future generations figure out, how we can do better. So I think those are some of the key takeaways for me, I guess, in the last few years.
Right. Wow.
Is it easier for you to study what you need to study to have us keep our stomachs, or does it matter to you as far as your...
It doesn't matter. I think you as individual patients have to do what's right for you.
Right.
We are going to learn something regardless. And I'll give you an example. For all the people that are out there getting surveillance instead of gastrectomy, you know what we're learning? I think we're learning that surveillance can be, for a lot of people, a relatively safe alternative to gastrectomy. And again, 7-8 years ago, I might have said, well, I'm not sure. And you guys probably know this. There are lots of doctors out there that if you said, oh, I'm not going to get my stomach out, I'm just going to undergo surveillance, they might say you're crazy because, oh my gosh, you have this gene mutation and you're at high risk for, developing a deadly cancer. My standpoint is wait a minute. Let's go back to the data I mentioned earlier. If we take out 100 stomachs and 95 of 100 of those stomachs already have early cancer in them, right? Mm-hmm. And then the other statistic that you guys asked is, well, the rates of cancer, as we've learned more, seem to be lower. They're not 80% like we used to. So if only 25 to 40% of people with CDH1 might develop stomach cancer in their lifetime, how do we account for that big drop-off, meaning 95% or so of people, maybe 100% of people with CDH1 have those cancer cells in their stomach, but only 30 to 40% are ever going to go on to develop advanced cancer? What happened to the other, 60, 70% of people? Why didn't... So this is where I say, wait a minute, surveillance may be good for some people, especially for the ones who are never going to get stomach cancer. Right. Our problem is figuring out who, exactly. Right? So if I could say, hey, Polly, you're never going to get advanced stomach cancer, that'd be great. We know exactly what to do.
Right. Well,
but we're not there yet.
If it advances to 1B, we would require chemo, right?
So in general, T1B or above, we generally talk about chemo. I think it would just every case is unique. You might have discussions, but definitely T2 or above, we talk about chemo. And again, the reason why we give chemo is just because stomach cancer is a gnarly cancer and nobody wants to take a chance in it coming back. We think that the likelihood of it ever coming back at that T1A stage is, as close to zero as we can possibly imagine. But at T2, there's definitely a known recurrence rate. And even if it's 10, 20%, that's a pretty high chance. So yeah, that desire to want to avoid chemotherapy, I think, is a valid, kind of concern. But again, it's why we need to figure out better ways to either detect it early or figure out when or why or how it's going to grow and advance. And that's the importance of the research.
Is that recurrence from the stage 2 post-gastrectomy? Like, would you say?
Yeah, okay. Yeah. Meaning even if you take the stomach out, at least if you look at, data on patients with stomach cancer in the United States, there's just a known percentage, regardless. T2, you take the stomach out, in theory, you're curative. There's going to be a small percentage of those that will have a recurrence at some point. Right. And there may be lots of reasons behind that. That's why those data are can be sometimes hard to interpret, but that's where then the chemo comes in, right? Because chemo is all about reducing risk of recurrence, at least in the setting of curative cancer.
Mm-hmm. Mm-hmm. Okay. Well, I feel so blessed to have you as our doctor and watching over us, and I'm so grateful that we stumbled upon your study. And for those of you out there who have not joined the study yet, I highly advise that you go to the NIH right now and sign yourselves up, because you are the man, and I feel so confident under your hands. And
definitely,
we just appreciate all you've done for our family. And yeah, we love you so much.
Well, I appreciate that, and I'm not good at Instagram, but if Gloria's around, you tell Gloria I said hello.
We will for sure,
and I'll be seeing you.
Yep,
June 16th.
I know
for my stuff.
I know, it's on my calendar. I got a big black no, I'm just big black heart on my calendar. I don't know.
Okay. Well, thank you so much. We appreciate you for taking time out of your day to talk to us.
Yes. Is there anything you want to leave us with? Any words of wisdom?
No, I thought. No, well, listen. I think words of wisdom is, if you have CDH1 or CDH1 is in your family, yes, it's reasonable to be worried, but get tested, because if you're negative, that's great. If you're positive and you have the mutation, then there's folks like us out there that can help. And having that knowledge, I think, is helpful. And so you guys are doing a great job spreading the word. I love the stuff on Instagram and YouTube and all the stuff that you guys have been doing. So keep up the good work. I wish I had looked better, because I notice everybody that you interview, they look like amazing. And I feel like
makeup.
I don't have stage makeup, but maybe I need to look into it.
You look great. You look great. Don't sell yourself short.
Okay, guys.
All right. Thank you so much, Dr. Davis.
Okay, bye-bye, guys. See you later.